My name is Marissa Mitchell, and I'm happy to be talking to you today about pediatric motor speech disorders, diagnosis, and treatment. Before I begin, I just want to mention that I have no relevant financial or non-financial relationships to any of the products or services that I talk about. So I will be talking about some manualized treatment approaches as well as some technology, but I have no relationships with any of those companies. So today I hope to answer the following questions. These are oftentimes questions that parents will ask me when they first get a diagnosis. So what are motor speech disorders? What causes them? How are they diagnosed? What therapies and treatments work? And at least equally important, what doesn't work? And what do we know about long-term outcomes? So what do we know about prognosis? So first, what are motor speech disorders? Before I can really talk about what motor speech disorders are, I really have to talk about how speech happens. Now, this will be a very simplified version of how speech happens, but it is important to consider when we think about motor speech disorders. When most of us talk, we don't really think about what we're doing, but it's a really complex process. So before we even open our mouths, the first thing that happens is we have to decide to communicate, and then we have to formulate our message. This is called the cognitive linguistic stage. Next is transcoding. That's where we have to plan and program the sequence of motor movements that are required to produce sounds. After that, we actually have to execute or carry out the motor plan. And we do this by coordinating our articulators. So these are the lips, tongue, jaw, soft palate, and respiratory system that typically are all working in concert to produce speech. And lastly, there's sensory feedback. So after we produce a message, we have to process what we've just done. So auditory, we ask ourselves, how did it sound? And then proprioception is where we think to ourselves, how did it feel? That sensory feedback is really crucial in that we then fine tune what our next message is going to sound like. So for the purposes of talking about motor speech disorders, the two phases of speech production that are going to be most important would be transcoding, so the planning and programming, and then execution of the motor plan. So we can define motor speech disorders as speech sound disorders or problems with articulation that's caused by deficits in either motor planning and programming or execution. There are three main types of motor speech disorders: childhood apraxia of speech, dysarthria, and then a broader category called speech motor delay or motor speech disorder not otherwise specified. This is a broad category that includes children who might not fit neatly into either an apraxia or dysarthria diagnosis, but they have some features of both. Motor speech disorders can be developmental, so they can occur from birth or from the perinatal period, or they can be acquired later in life. They're also variable in severity. So some children present with very mild problems. They might not have much changes to their functional communication skills, whereas other children present with severe motor speech disorders and really have trouble producing words in a verbal manner. It's important to consider that motor speech disorders are part of a much larger umbrella of pediatric speech sound disorders. Much more commonly are children who have trouble with that initial cognitive linguistic stage. They have trouble formulating their message and knowing when to use one sound over another. Kids who have trouble with this oftentimes present with what's called a phonological or articulation disorder. And these are by far the most common pediatric speech sound disorders. On the other end of the spectrum, a child might not have any problems with motor planning or motor execution, but rather they might have an anatomic or sensory issue that makes speech difficult. These might be children who have a severe lip or tongue tie, a cleft palate, or even a hearing impairment where they can't actually hear what they're trying to produce. How common are motor speech disorders? The short answer is not very common at all. So it's really challenging to get a good idea of general population prevalence, but the best information I could find was from a recent study from a few years ago among children ages 4 to 8, where these researchers estimated that both apraxia and dysarthria occur in approximately 1 in 1,000 children. Speech motor delay, which is the broader category, is a little bit more common, approximately 4 in 1,000 children. But it's important to keep in mind that certain clinical populations present with motor speech disorders much more commonly. So kids with complex neurodevelopmental disorders like intellectual disability, global developmental delay, or autism oftentimes present with motor speech problems. And individuals who have certain genetic conditions, we know that they're predisposed for certain motor speech problems. If we take a look at children who present simply with speech delay, if we were to follow those children over time, only about 18% of them would actually meet criteria for some type of motor speech disorder. So even among children with speech problems, motor speech disorders are relatively rare. The other thing to keep in mind is that most kids who present with apraxia and dysarthria present with several different co-occurring diagnoses. It's very uncommon for a child to present just with a motor speech disorder and nothing else. Most commonly, we see kids who also present with expressive language impairment and sometimes receptive language trouble, so difficulty with comprehension as well. Other common comorbidities include things that implicate the motor system, which is probably not a surprise as motor speech disorders are impacting motor speech, motor planning, and motor programming. So things like gross motor delay early in life, developmental coordination disorder, which is also referred to as dyspraxia, or on the far end of the spectrum, the more severe end, we might have a child who presents with cerebral palsy. Other common diagnoses include intellectual disability, autism, and epilepsy. So first I'll talk about childhood apraxia of speech. This is defined by the American Speech, Language, and Hearing Association as a neurological childhood speech sound disorder in which the precision and consistency of movements underlying speech are impaired in the absence of neuromuscular deficits. And that last part is important, in the absence of neuromuscular deficits, because if there are neuromuscular problems, the child is more likely to present with dysarthria. The core impairment in apraxia, on the other hand, is in the planning and programming stage, where children have difficulty with the spatiotemporal parameters of movement sequences, and this results in errors in speech sound production and prosody. So in short, we can think of it as a complex, higher order motor system deficit in motor planning and programming. Praxis, the root praxis, is a Latin root that actually means planned movement. And so children with apraxia have specific trouble with planning their movements. A quick note about terminology, because this can get a little bit tricky. Childhood apraxia of speech is the commonly accepted diagnostic term nowadays, but until relatively recently in the US, it was referred to as developmental apraxia of speech. Developmental was substituted with childhood for a couple of reasons, mainly because developmental has the connotation that it might simply be a delay that a child simply grows out of with maturation. And we know that to not be the case. Children with childhood apraxia of speech need direct and intensive intervention to make reasonable progress. Another term that you'll oftentimes see is something called dyspraxia. And this is still how apraxia of speech is commonly referred to in the UK and in parts of Europe. In the United States, however, we most often refer to it as apraxia. These all refer to the same thing. There's no gold standard test that will tell you whether or not a child has apraxia. And in fact, it can be really challenging to make that differential diagnosis. The consensus among motor speech disorder experts, however, are that there are three features that are most commonly seen and are therefore diagnostic of apraxia. The first one is inconsistent errors on repeated productions of syllables or words. This is also referred to as token-to-token variability, and it refers not just to inconsistent speech production between words, but it actually refers to inconsistent speech production of the same word on repeated attempts. So on one occasion, the child might come out with a word sounding totally fine, and the next time they struggle with that very same word. Secondly, we oftentimes see lengthened and disrupted co-articulatory transitions between sounds. So that's where kids with apraxia really struggle. It's with actually moving from the motor sequences required to produce one sound to another. And so oftentimes their speech might sound choppy. They might insert some pauses in between syllables or in between words. And this results in unusual prosody and abnormal stress patterns. So a child, even if they're able to produce the sounds correctly in the word that they're saying, a child with apraxia might actually sound robotic or not quite right. So taking the word banana, for instance, they might put the stress on the wrong syllable and instead say banana. Some additional features, so these are less diagnostic but are oftentimes seen, are that kids have a limited repertoire of vowels and vowel distortions. So most children who present with run-of-the-mill phonological and articulation disorders, even if they're really severe in nature, they oftentimes produce the vowels correctly, but where they struggle is with consonants. This isn't the case with apraxia. Many kids with apraxia do struggle with vowels in addition to consonants. They oftentimes present with unusual or idiosyncratic error patterns. Speech therapists who work with kids with apraxia often complain that they're not able to take a good language transcript simply because the errors that they produce are so unusual in nature that there's no way to write them on paper. Kids often have a slow rate of speech with some observable physical groping, where the child might employ trial and error to figure out where they're supposed to place their tongue or their lips or their jaw. And so you can actually see the child physically struggle. They oftentimes produce increased errors on longer, complex utterances compared to simpler utterances. They oftentimes have better articulation of automatic or overlearned utterances. So things like thank you or counting to 10 might sound fine because the child has overlearned them to the point that they become automatic. Another thing we oftentimes hear from parents is that when the child was younger, they presented with limited babbling. Kids with apraxia were oftentimes described as quiet infants. And lastly, kids with severe apraxia oftentimes also present with co-occurring oral apraxia. This results in feeding problems, so trouble with swallowing, trouble with chewing. On the more severe end of the spectrum, some kids actually will need a feeding tube. So we spoke about dysarthria. Now I'm going to discuss the second major diagnosis within the motor speech disorder umbrella, and this is dysarthria. And if you recall, dysarthria occurs at the level of motor execution. It's a motor speech disorder that's caused by weakness, paralysis, or incoordination of the muscles that are used to produce speech. It's often associated with either low muscle tone, which can be referred to as hypotonia, or increased tone, which is referred to as hypertonia or spasticity. It typically results, regardless, in what we would hear as slurred or imprecise speech. And dysarthria is unique among speech sound disorders in that it can impact any or all speech processes. So not just articulation, but also respiration. So perhaps a child doesn't have sufficient breath control. Resonance. So oftentimes kids with dysarthria have trouble moving air through the speech mechanism and it might escape inappropriately through the nose. And prosody as well. There are several different types of pediatric dysarthria. Spastic dysarthria typically refers to those children who present with hypertonia or increased muscle tone. Flaccid dysarthria is more often seen among children who have hypotonia or low muscle tone. Ataxic dysarthria, the child's tone might actually be okay, but they have trouble coordinating their movements. Hyperkinetic dysarthria refers to children who have extra movements that they're not able to control. So we sometimes see this in pediatric Huntington's disease or kids who have other types of choreas or movement disorders. And mixed dysarthria is essentially a combination of features from several of the other types. The main features of dysarthria vary widely depending on what type of dysarthria the child is presenting with. But in general, the kid will present with a slow speaking rate. Their vocal quality might sound breathy, as is the case in flaccid dysarthria, or it could even be harsh, hoarse, or strained, which is more often the case with spastic dysarthria. Regardless, they almost always present with imprecise and slurred speech. Most sounds are distortions, which is in contrast to substitutions or deletions, which are more common with kids with apraxia. Sound errors are often consistent. So if you recall, one of the hallmark features of apraxia is inconsistent production of the same word. Kids with dysarthria do not typically exhibit this. Their sound errors are oftentimes consistent between words as well as within words. They oftentimes have difficulty regulating pitch and loudness, and children might present with resonance problems. So as I mentioned before, kids with flaccid dysarthria might have a nasally sounding voice because they have trouble with the muscles that are required to close off that passageway to the nose. What causes motor speech disorders? There are three main groups that we can kind of consider. The first would be children who present with an acquired neurological impairment. The second group would be children who have complex neurodevelopmental disorders that are the result from either genetic or metabolic conditions. And the last group are those individuals whose motor speech disorders can be considered idiopathic. So neurological impairment, I'm referring here to any type of infection, illness, or injury or trauma to the brain. So this could be caused by stroke, it could be caused by traumatic brain injury, and these insults could occur before, during, or after birth. These kids will typically present with an abnormal MRI or brain scan, and in these cases are more likely to result in dysarthria compared to apraxia, because it's often associated with a broader neuromotor dysfunction. So kids who have an abnormal MRI very rarely present with an isolated speech problem. The second group of children are kids with complex neurodevelopmental disorders who might present with some type of genetic or metabolic condition. Some of the more commonly seen genetic conditions that we know are associated with motor speech disorders are Fragile X, Down syndrome, galactosemia, 22q11.2 deletion syndrome, also referred to as velocardiofacial syndrome. And the last group of individuals I think are of particular interest to this group here today, and that's SETBP1 related disorder. So there was a recent study that came out within the last year that indicated that up to 80% of kids in their study presented with childhood apraxia of speech. So this seems to be one of the core features of SETBP1 related disorder. And if we look at the broader group of children with apraxia, we're beginning to find that more and more kids do have some type of a positive genetic finding. One study that came out last year showed that approximately 1/3 of their apraxia cohort, when they had genetic testing, had some type of positive or pathogenic finding that occurred in multiple different genes. There's no one specific gene that kids are consistently presenting with, but we do know that genetic testing might at some point in the future be indicated for a child with apraxia or dysarthria. However, the third and very clearly largest group of kids who have a motor speech disorder are those with idiopathic cases. And idiopathic essentially means that the cause is unknown. So these are kids who might have genetic testing, but don't present with any identifiable genetic etiology. If they have an MRI, it typically comes back looking completely normal. And so these are children who we don't really know what caused their motor speech disorder, but we oftentimes can assume that it's the result of multiple different genetic and environmental factors. How are motor speech disorders diagnosed? So first, the most qualified professional to diagnose a motor speech disorder is a licensed speech-language pathologist, preferably one who has some type of a background or additional training in motor speech disorders. Certainly other professionals such as neurologists and developmental pediatricians are an important part of the care team, especially since most kids who are presenting with motor speech problems have other types of common neurodevelopmental issues. And there are certain considerations that we always want to think about when we're making a diagnosis. The first one is that a differential diagnosis is really very difficult, if not impossible, in children who are younger than 3 years. There are several reasons for this, but the most important reason is that most kids presenting with speech delay at that point really have very limited verbal speech. And so we know that a child needs to have a sufficient amount of speech, preferably phrase level or sentence level, or at least attempting to produce longer utterances in order for the speech therapist to get enough information to make a reliable diagnosis. So in those kids who present as nonverbal or minimally verbal, we might suspect a motor speech disorder, but we wouldn't really be able to reliably make that diagnosis. And lastly, I think I mentioned before, there's no gold standard test for apraxia or other motor speech disorders. It would be a lot easier if there were, but typically the evaluation has to consider many different things, and it really is a diagnosis of exclusion. I think this chart summarizes well what some of the challenges are in making a differential diagnosis. There really isn't any given feature that we always see in any one of these conditions. So oftentimes when a child presents with extremely poor speech intelligibility, meaning they're very hard to understand, there's an assumption that they must be presenting with a motor speech disorder of some type. But in reality, there are many children who have severe phonological or articulation problems that have very poor speech intelligibility. And so this alone is not really a good diagnostic indicator that the child has a motor speech problem. Some of the other features that we've already talked about, things like abnormality in muscle tone, inconsistent errors, vowel distortions, these are things that typically can occur in more than one speech sound disorder. And so it's important to consider all of these things as part of the comprehensive evaluation. Elements of a motor speech evaluation always include a good caregiver interview, And the reason for this is the parent or the caregiver is with the child more than anybody else. And so they can provide really good insight about what that child's speech production looks like across environments. When I see a child in the clinic beforehand, I always do a comprehensive review of any previous multidisciplinary testing, which might be through school or might be through private outpatient clinics. I also take a look at the medical and birth history to see if there's anything there that might impact the neuromuscular system. Next, I'll do a structural and functional examination. I take a look at the oral mechanisms. So those are the articulators that I mentioned before, things like the tongue, the teeth, the jaw, both the structure as well as their movement and their function to make sure that all looks okay. I look at the respiratory function of the child. I mentioned before that kids with dysarthria oftentimes present with really poor breath control, and this can impact their voice quality as well as articulation. I'll oftentimes have the child try to sustain phonation, so essentially try to make a sound for a long period of time. Kids with motor speech disorders, and especially with dysarthria, really struggle with this because they have an inefficient speech mechanism and they won't be able to sustain the same sound very long. And lastly, I look at velopharyngeal function, which is essentially how the velopharynx works. Is the child able to make the movements that are required to close off the speech mechanism so that the air flows appropriately through the mouth rather than escape through the nose? Next, I will always administer, or at least I attempt to administer, some type of standardized assessment. Even if the focus and the concern really is on speech sound production, I will always give tests looking at both receptive and expressive language skills, because we know that most kids who have a motor speech disorder will present with some type of language disorder as well. Some of this might be direct testing. For younger kids, some of it might simply be a standardized caregiver report measure where the caregiver has a list of either sounds or words that they report their child can do. Next, and equally important, would be non-standardized assessments. So these are assessments that give me really important qualitative information about how the child produces speech, but it might not give me a standard score, something that I can compare to a larger group of children. Dynamic testing would include some type of evaluation procedure where the child is giving incremental levels of support to figure out what support is necessary for the child to be able to produce certain sounds or certain words. One example of a test like this would be the dynamic evaluation of motor speech skill. Clinical observation and language sample transcription are often used hand in hand, where I'll look at the error patterns that a child produces as they're doing some particular task. Once the motor speech disorder is diagnosed, the next question is, how do we treat it? Some considerations are that speech therapy should be provided by a licensed and certified SLP, particularly one who feels comfortable and might have some additional training in motor speech disorders. Just like there's no gold standard test for apraxia or dysarthria, there's also really no gold standard or one-size-fits-all treatment. What we want to do is take into account that specific child's age, their developmental level, their ability to attend, as well as the severity of the disorder. Evidence-based decision-making is a really important part of that process. So before the speech-language pathologist decides on what type of treatment is appropriate, they really should be considering the research evidence. They want to take into account the levels of evidence. So for instance, expert opinions or single case studies certainly don't hold as much weight as a randomized control trial or a systematic review of the literature. And I do want to make the note that most manualized and marketed approaches that are on the market right now have limited research support. So just because something is packaged in a great way and it has a website and they might do trainings, it doesn't necessarily mean that there's a lot of research support for that particular method. There are two main treatment approaches, and these are not mutually exclusive. And in fact, for the most part, I tend to use them both at the same time. The first would be direct speech therapy that has a goal in improving speech intelligibility. So this is looking specifically at the child's speech production, and it's utilizing motor learning principles. The second main treatment approach would be improving functional communication through the use of augmentative and alternative communication, as well as compensatory strategies. So looking first at direct speech therapy with a goal of improving intelligibility, even though there are many different ways that you can get at the same goal, we do know that all of these marketed approaches have certain effective components. Most of them will utilize the principles of motor learning. So if you take a look at the picture here, this is a person who's learning how to play the piano. And if you have any type of personal experience learning how to play an instrument or learning how to practice a new sport or hobby that requires motor movement, you probably recognize that you have to have a lot of practice. And there's the old adage that practice makes perfect. And it's the same thing for our kids who have apraxia or dysarthria. Therapy should be frequent. A good rule of thumb is that it should occur at least 3 to 5 times a week, and it should also be intense. So intensity refers to the amount of actual practice that the child is getting within a single session. For that reason, I usually recommend that at least some therapy is provided individually because it's more effective and more intensive than group therapy. Another principle of motor learning would be multisensory cueing. So to take the piano analogy again, when you're first learning how to play your scales, you might actually have some type of a color-coded system on the keys, or you might actually write out the notes directly on the keys. So this would be a visual cue that helps tell you where you should be placing your fingers. And it's the same thing when you're dealing with the child who has a motor speech problem. You might use several different sensory modalities to cue the child as to where their lips or their jaw or their tongue should be at any given time. Another important component is to provide direct and immediate feedback. So oftentimes kids, particularly children who have trouble with motor planning, they might not get the feedback that a typical child would when they're trying to execute a speech plan. And so it's important for the speech therapist early on to give direct and immediate feedback so they know whether or not something sounds or feels correct. One focus of therapy should also be on rhythm and prosodic facilitation, and that's one way that this differs from typical speech sound therapy, which usually has an isolated focus on speech sound production. Kids with apraxia in particular, and with dysarthria, often have difficulty with prosody, and so this has to be targeted directly. And lastly, progressive approximation and shaping are strategies in which we might break down a word into its component parts and practice each small and simple component part, and then slowly add to it over time so that the child can eventually produce more complex utterances. With all of these things in mind, there are some manualized treatment approaches that have a reasonable amount of research evidence. The strongest research evidence are in the rapid syllables transition treatment, or REST, and this is targeting children who are ages 4 to 12 with either apraxia or ataxic dysarthria. There's the Newfield dyspraxia program, which you can probably tell is based in the UK since they use that term dyspraxia. This is targeting ages 3 to 7 with all types of severe speech sound disorders, which includes apraxia and dysarthria. The dynamic temporal and tactile cueing system, or DTTC, is aimed at young children who have moderate to severe apraxia. All of these three are looking at those principles of motor learning that we had recently discussed. The last one is a little bit different. The Integrated Phonological Awareness Training Program isn't really a motor learning approach. It's looking more specifically at the level of phonology, so that cognitive linguistic level. However, there is some research support that shows it can be effective in treating kids with apraxia as well. So we're discussing the direct speech therapy with the goal of improving speech intelligibility, but the second main focus of therapy for a child who has either severe apraxia or dysarthria would be the use of augmentative and alternative communication, or AAC. AAC refers to all tools and strategies that are used to supplement or replace speech when it's not sufficient to meet a person's daily needs. And this can include sign language, it can include letterboard or even pencil and paper, or it could be high tech and look like something like an iPhone or a tablet-based device. There are two broad categories of AAC, unaided and aided. Unaided refers to strategies that utilize the user's own body. These are things like facial expression, vocalization, gesture, and sign language. Aided AAC, on the other hand, refers to some type of tool, whether that's something with a battery or plugged in, or something that's low tech. So we can think of aided AAC as part of a continuum. On the one side, we have low tech strategies. These can include pencil and paper, alphabet boards, picture books, things like the Picture Exchange Communication System, or PECS. If we move up the ladder, then you get to mid-tech strategies. These are things that oftentimes allow you to record either one or several simple messages, but they're not dynamic in nature. And at the high-tech end of the spectrum, we have what's called dynamic display speech generating devices. These can either be dedicated devices or they can be off-the-shelf technology like the iPad or other tablets with some type of a communication app. There are certain considerations when we're implementing AAC. The first is that the AAC assessment should be conducted by the SLP, but certainly with input from family, teachers, therapists, and doctors. Another important point is that there are no prerequisite skills that are required by the child. In years past, it was thought that children weren't ready for AAC if they weren't able to follow directions or attend. And in reality, what's important is that you match that individual piece of technology with the unique skills and needs of the child. Verbal children can also use AAC to supplement their speech. So many children who have motor speech impairment might present with phrase level or even conversational speech. However, they might be really hard to understand for people who don't know them well. And in these situations, they can still benefit from AAC to supplement the speech that they do have. AAC is not just for kids who are nonverbal or minimally verbal. And lastly, it's also important to understand that using AAC will not prevent or discourage a child from learning how to talk. I think sometimes parents or school teams are concerned that by introducing AAC, kids will use it as a crutch and then they're not going to be motivated to produce verbal speech. The good news is we have quite a few studies, some of which are listed here, that shows that that's simply not the case. And in fact, in some situations, employing AAC might actually accelerate speech production. So we talked about some of the things that do work, but what doesn't work? Well, we know that certain methods have been discredited and some can even be harmful. So if you type in particularly Apraxia into Google, you're going to see a lot of different companies that are trying to sell vitamins and supplements, things like megadoses of vitamin E or omega-3 fatty acids, fish oils. Unfortunately, there's just not a lot of research that shows that this is effective. And in fact, it might actually be dangerous. A lot of these things are not regulated by the FDA. You're not really sure what you're giving your child. And so at this time, I really can't recommend them. Additionally, non-speech oral motor therapy has been found to be ineffective for kids with motor speech impairment. Non-speech oral motor therapy refers to things like blowing through straws, blowing through whistles, using chewy tubes or things that are purported to strengthen the musculature that's required for speech. But really what we know through research, the only thing that works for kids who have motor speech disorders is practicing speech itself. The last two things are facilitated communication and the rapid prompting method. These two things can look a little bit like AAC, but rather than having the child produce their own message, what we've found over time is that the facilitator is helping them produce the message for them. And so authorship comes into question. And so for these reasons, the American Speech, Language, and Hearing Association has taken a strong stance that they do not recommend using either of those strategies with children who require AAC. And lastly, what do we know about long-term outcomes with kids who have motor speech impairments? There are specific child-specific considerations, and these are things that are unique to that individual child. So it makes more sense to take prognosis on a child-by-child basis than lump all kids with motor speech disorders into the same category to look at prognosis. So the first consideration seems pretty obvious, but I'll mention it anyway. It's severity. So, clearly a child who is presenting with a milder apraxia or dysarthria is likely going to have a better long-term prognosis than a child who presents with very severe apraxia or dysarthria. Another thing that we want to take a look at are a child's co-occurring or comorbid diagnoses. So children who have a comorbid intellectual disability or behavioral problem might prevent them from making the most out of speech therapy. So the child's ability to attend or to follow directions might make it so that they make slower progress in therapy over time. Next, self-awareness and motivation certainly play a role. So some children who have apraxia or dysarthria might have very limited self-awareness that their speech can be a challenge for others to understand. On the one hand, this is a blessing in that kids tend not to get very frustrated with their speech. But on the other hand, these kids often have a low motivation to actually change their speech to make it easier for them to understand. And for that reason, they might make slower progress in therapy. And lastly, when I'm talking to parents and counseling about what I expect for them in the future, I always say that one of the best indicators for ultimate prognosis is what progress they make initially in therapy. So when I see kids for their initial evaluation, where they might get that diagnosis of apraxia or dysarthria, and a parent asks me what they can expect 5 years down the road, I always say I would much rather see them back in 6 months or in a year once they have the right supports to see what kind of progress they make. Because we know that kids who make good progress over time, and we have several data points that we can follow them over time, we'll get a better idea of ultimately what their trajectory is and where they'll end up. So we were talking about child-specific considerations, and these things by and large are things that are individual to the child, and really there's not much that we can do to change those. However, what we do have control over oftentimes are these treatment-specific considerations. The first is a child's age at onset of speech therapy. So we know that kids who get speech therapy earlier in life oftentimes have better long-term outcomes. We also know the frequency and intensity of speech therapy makes a huge difference. So kids who have more frequent and intense speech therapy tend to make better progress than kids who might only get speech therapy 1 or 2 times a month. In addition to that, we're looking at the appropriateness of therapy and the use of evidence-based interventions. And so, a speech therapy that's, instead of looking at simple speech sound production and might take a phonological approach, might not be as appropriate as those that employ those principles of motor learning that we discussed earlier. And lastly, and this is huge for our kids who have motor speech disorders, family support and carryover are key. So a speech therapist can only physically be with a child, at most a couple of hours a week, but the family's with the child all the time. And so they're a really important part of the treatment team who can work on home practice activities and carryover activities when the child's not currently in speech. So prognosis, these are the main takeaway points. And there's a picture here of a crystal ball. And I oftentimes tell families that I wish I had a crystal ball and I could predict the future and tell where your individual child could be in 5 or 10 years. But there are some things that we know are typically the case. The first is that many, but certainly not all, children with motor speech disorders do go on to become proficient verbal communicators. And some children in adulthood are able to achieve what we would consider to be normal speech. So there's a subset of children who maybe when they're tired or fatigued, or they have, a new word that they're unfamiliar with, they might have a little bit of challenges with articulation, but for the most part become totally conversational, and the average person wouldn't be able to tell that their speech sounds any different. However, there are some children who will have persistent motor planning deficits even into adulthood. We know for any child that frequent and intensive speech therapy is necessary. So motor speech disorders aren't like a simple speech delay where we can assume that a child is going to simply mature and outgrow it over time. We do know that kids with motor speech disorders do require direct speech therapy. And lastly, it's important to consider that prognosis depends on the characteristics of that individual child. And so it's important when you're prognosticating that you're taking a look at that individual child's strengths and needs, as well as their progress in speech therapy over time. So I hope you found that helpful. I've enjoyed talking to you today. And I do have a list of references and resources that you might find helpful. And we will try to find a way to get those to any families who would like a list of them if you want to do some additional reading on your end. Thank you very much.
Great. Welcome everyone to the Diagnosis and Motor Speech Disorders Q&A. My name is Cora Taylor, and I'm joined here today with speech therapist Marissa Mitchell. We are excited to get started with the Q&A session to address some of your questions. For everyone listening in, you should be able to see and hear me on your screen, although I won't be able to see or hear you. We welcome you to ask questions in the Q&A box. Please remember to avoid including personal health information in your questions for your own privacy. We apologize in advance if we do not get to your questions, but we will try to cover as many as possible. And since there are many genetic groups represented, it might be difficult to answer very specific questions. With all that said, let's start the Q&A discussion and hear from you all. And let's begin with our first general question. First question for you, Marissa. Most people have a hard time understanding my child's speech. Is there an age when, if a child's speech is still unintelligible, that it is unlikely to progress further?
That's a really good question and a difficult one to answer. To my knowledge, there's no research study out there that really shows us that there's, a cutoff age for speech intelligibility, at which point a child won't make any more progress. I think the best prognostic indicator is the child's rate of change over time. And so even if you have an older child, but maybe they haven't been in therapy that long, I would say, the chances of them greatly improving their speech are probably still pretty good with the right supports. On the other hand, if you have a child who's been in speech therapy for a very long time and you look at their rate of progress over time, and maybe over the last few years, you've seen a bit of a plateau, I certainly wouldn't give up on speech therapy, but at that point, it might be time to either try to increase the intensity or maybe even try a different approach. So whether that's with a new therapist or maybe a new program, something, because that's telling you that what's going on right now is probably not working very well. So the short answer is, there's no age cutoff for intelligibility that in my personal experience that I've found or in research. Really what we want to do is look at that individual child's progress over a specific period of time.
Great. Let's go ahead and go on to the next question. So my child was in therapy doing the prompt approach. I live in Canada, and that type of therapy seems to be the one mostly used. Should I be looking for alternative options?
I think it depends on how well your child's responding to it. I didn't really mention prompt therapy directly in my presentation, simply because there's not a lot of evidence to show that it's effective. That doesn't mean that it's not utilizing principles of motor learning, which I talked about in the presentation. It does certainly utilize a lot of those same principles. It's just not one of the better studied, manualized and marketed approaches. So it doesn't have quite a bit of evidence. If your child, if you feel like they're making good progress in speech therapy, then I think that's probably the most important indicator that what's going on is helping them. So I would say if they're in prompt for a while and it doesn't seem to be working, then I think at that time, you certainly might want to consider some other evidence-based options.
Great, thank you. Is there a recommendation or method or treatment for children beyond teenage that had initial successful treatment?
Beyond school age. So just to make sure that I'm understanding the question, specific therapies for adult participants potentially?
Yeah, older individuals.
Older individuals. So there aren't any approaches that I'm aware of that have a lot of support for developmental motor speech disorders in older individuals. I suspect that the same techniques that work in a pediatric population would also work for an adult population. I know that there's an entire other set of literature and expertise in the area of acquired motor speech disorders. So for instance, individuals in adulthood who have had stroke, who have, dementia, or some type of degenerative process that's impacting their motor speech production. So there certainly are programs specific to adults, but those are typically more focused on acquired neurological issues. When it comes to developmental motor speech disorders, which is what I was talking about today, I suspect that the same approaches that work for children would also likely work for older adults as well.
And a question maybe a little bit about younger kids. So you mentioned in your presentation that there needs to be a sufficient amount of verbal speech. But when without a diagnosis, it might be challenging to access these apraxia approaches. So how can you get an SLP on board with trying some of these apraxia approaches when you can't get an apraxia diagnosis?
That is a challenge. I mean, I oftentimes see kids who are, minimally verbal or nonverbal, and certainly we might suspect a motor speech disorder simply based on their history or the fact that they haven't made much progress in therapy. Maybe they have some other common comorbid risk factors, things like, motor impairment. Maybe they were quiet babies. Maybe they have feeding impairments. In those situations, I will oftentimes write in my reports that it's a rule out diagnosis or suspected motor speech impairment pending, additional evaluation over time as their expressive skills develop. And so in these cases, certainly there's no harm in beginning some type of a motor speech impairment program, and that usually involves more intensive therapy. I usually tell families, let's say the early intervention is providing speech 1 hour a week. And 1 hour might actually be sufficient, but in the case of a child where I suspect apraxia, I likely recommend let's break that hour into multiple pieces. I'd rather the child get 3 20-minute intensive sessions a week versus one block of an hour. We know that when it comes to motor planning, more frequent practice is oftentimes the better approach. And so, in these situations, what I'd say is that there really isn't a harm in trying some motor speech techniques in therapy with a young child if a motor speech disorder is suspected, even if it's not confirmed.
Great. And is there any evidence that music improves speech production? And if so, any particular type?
There's no evidence that I'm aware of that any type of a musical program or music therapy improves speech production. I know that sometimes individual children might do well with music therapy when it comes to attempting to communicate, or perhaps they find it motivating. And so it's a good way to just motivate them to participate in therapy. But when it comes to improving speech intelligibility, there's really no evidence that using music has any type of an effect on the child's speech intelligibility. We do know that the thing that works for improving speech is speech. It's practice with actual speech targets.
How do you find an SLP trained in REST or the DTTC approaches?
That's a good question. So I know on the ASHA website, which is, I believe, www.asha.org, there's a section for searching individuals, searching licensed SLPs in your area. And oftentimes SLPs on that website will list specific areas of expertise that they have or interest. And so sometimes you can find individuals through that. But I oftentimes think the best thing you can do is if you have a child who has an apraxia or other motor speech diagnosis, is simply to ask the speech therapist what their comfort level is using a variety of techniques. And I think most therapists that are out there know what they know and what they don't. And I certainly have referred out individuals who I don't feel comfortable treating if they're presenting, for instance, with feeding concerns, as I know that that's not really my area of expertise. And so I do think just having an open dialogue with your child's speech therapist is probably the best way to go. Certainly, if they don't feel comfortable trying a new technique, they might have a colleague who they know of who they can refer you to.
And a question here about accessing services. So what suggestions do you have for caregivers in navigating insurance companies when insurance or cost of more frequent or intense speech therapy is prohibitive?
That is really a challenge. And certainly that's a challenge for many kids who present with neurodevelopmental disabilities, not just children who have motor speech impairment. It's been my experience that when a child does have a motor speech diagnosis, sometimes their particular insurance plan is more likely to cover speech therapy simply because of the diagnostic code that's used, which is a neurological code rather than a developmental code, which many insurance companies have as an exclusion of what they'll cover. But really it boils down to, what your individual insurance plan does do. You certainly could contact your insurance company directly. Oftentimes you can be assigned a case manager where they can make exceptions on a case-by-case basis when it comes to your individual child. The other thing that you might want to do is take a look at certainly therapies through school, therapies through early intervention should be provided to your child free of cost. So clearly that's the first place that I would look and make sure that your child's individualized education plan or IFSP have enough speech therapy written into it. So that would be the first thing I'd recommend. But if you're looking specifically at private outpatient options, that's really going to vary based on what particular insurance you have. Another good option would be taking a look at local university clinics. So if you are lucky enough to live by a university that has a good communication disorders program, frequently graduate students will provide therapies in their on-campus clinics. And those therapies are oftentimes much less expensive. They usually have a sliding scale, even for individuals who don't have any insurance. So that would be another option as well.
Great. And what tools or verbal or visual prompts would you recommend for students who have a hard time communicating, students who are using maybe 3 to straightforward utterances, but poor vocabulary skills?
It probably depends on what your individual child's working on, what their goals are. So certainly I would, in the case of a child who has some verbal speech, but maybe is hard to understand, or maybe they're not able to elaborate on their short sentences, I certainly see a role for augmentative and alternative communication in those situations. So potentially the use of a speech generating device or even pictures. And that would be specifically if there are communication breakdowns where, the partner's not understanding what that child's trying to say, then you can use AAC in that situation to supplement what they're doing. So it's not a replacement of the speech they have, but it is going to improve their functional communication skills in the classroom.
Great, thank you for that. So the next question is coming from a family who's trilingual, and they're asking, they have a child who has a significant speech delay and asking if they should reduce the number of languages spoken at home to make it easier or keep using multiple native languages very much naturally.
That's a great question. So research certainly supports children being raised in a bilingual environment, and there's no studies out there that indicate that exposing a child to multiple languages will hinder their language progress, will hinder their speech progress. And there's quite a bit of research showing that learning another language and being fluent in more than one language has a lot of cognitive benefits for the child as well. So certainly I think if you have a child who has apraxia or you have a child who has a significant language disorder, I don't think that I would recommend, only speaking in one language to the child. Usually what I recommend to families is that you should be using whatever language you're the most comfortable using. So whatever your home language is, even if that's not English, that's really what you should be using when you talk to the child. The most important thing is that they're getting a really good model. And so you want to make sure that you're speaking to your child in whatever language you feel is your strongest.
Thank you. And you mentioned that speech and feeding can be a problem together. Does that require different kinds of therapy?
Yeah, absolutely. That does require different types of therapy. So I mentioned, non-speech oral motor movements or exercises, things like blowing through whistles or, chewing on chewy tubes, that there's not a lot of evidence that that's helpful for speech production. But there may be some exercises that would be helpful with feeding therapy specifically. If you have a child who has, for instance, some muscle weakness, where they're drooling a lot, maybe they're having trouble closing their mouth while they're chewing, those children might actually benefit from certain, mouth exercises. There are also some specific techniques for children who have swallowing trouble. So if they're actually having trouble coordinating the motor movements for properly forming the bolus and swallowing it, there are specific therapies and exercises for those children as well. So I often recommend that if a child presents with a motor speech disorder and a co-occurring feeding disorder, that they get a comprehensive video fluoroscopic swallow study to make sure that they're not aspirating food, that they're safe when they're eating. You also have to pay attention to what types of textures the child might need in order to be safe. So that certainly is its own area of expertise. And I would recommend seeking a comprehensive feeding team evaluation if your child has trouble with feeding.
Thank you. And next question, my child is able to produce a wide array of words. And right now we're working on phrasing and forming sentences, but oftentimes the format of the sentences is jumbled. Like he might say, me wait, when he means I'm waiting. What's your suggestions for this?
Yeah, so what you're describing is very common, not just among children with apraxia. What you're really describing is a child who's having difficulty with expressive language production, and specifically morphosyntax. So knowing, what order to put words in, as well as what verb endings and other types of grammatical markers to use to make sure that they're making sense. And so the type of therapy that I'd be recommending for those kids is the same as I would for any child who's presenting with an expressive language impairment. It's certainly not unique to children with apraxia, although certainly if a child has difficulty producing certain sounds and words, that is going to impact their grammar skills. So those two things need to be targeted in a kind of hand-in-hand fashion. But I don't think there are specific language elicitation techniques that would be unique to a motor speech disorder. So I think any techniques that the speech therapist is using with other children with expressive language disorder would be effective with your child as well.
Thank you. And our next question is it a good idea to move the school start date or hold my child back a year to give them more time to catch up on language development?
We oftentimes are asked that question in the clinic, and certainly among children who present with a wide range of learning difficulties or developmental delays, not just motor speech disorders. And this is really a very personal decision for each family, and it depends a lot on your individual child. I usually tell families that there's no one size fits all approach, that, some children might benefit from going to school, even if they still have a significant speech impairment. Some children, particularly those children who currently have access to very intensive and good intervention, it might be reasonable to wait a year as long as you have them in the appropriate supports. What I would hesitate to do would be to recommend across the board holding your child back with the assumption that in a year, their speech is going to be at a significantly better point, especially if they're not currently able to access intensive services. So often the level of services that children get once they begin kindergarten is much higher than the level of services they're able to get when they're in preschool. This isn't always the case, and so it really depends on your individual specific situation.
Thank you. And should my child have an MRI if they have a motor speech disorder?
So I mentioned that there is one subgroup of children who present with motor speech disorders that are due to some type of obvious neurological insult. So these could be children who maybe had a brain bleed at birth, children who are very premature, oftentimes that's the case. Or if there's, if a stroke has been suspected, or early in life, maybe there's a traumatic brain injury. In these situations, if the child's presenting with global neuromotor dysfunction, maybe they have an abnormal neurological exam, then oftentimes a physician, a neurologist, or a pediatrician will recommend brain imaging. But for the average child who's presenting with a motor speech disorder but doesn't have global neurological dysfunction, oftentimes MRIs really don't reveal much. Certainly no specific findings that you could put your finger on and that would, change the child's prognosis or change the treatment approach. And so, this would definitely be a decision that you should make with your child's neurologist or pediatrician who has an area of expertise in neurological exams and knowing what to look for when it comes to recommending an MRI. But I think most kids who present with apraxia certainly would not recommend an MRI for most children.
Great. And you mentioned AAC earlier for some kids, and this question is that the child speaks at home and the parent is able to understand the child, but at school, other kids and the teachers have a really hard time understanding them. And there's concern that if they use the AAC device at school, they'll stop trying to talk at school. Do you have any recommendations in that case?
Yeah, so there isn't a lot of research evidence that indicates that introducing AAC is going to prevent a child from being motivated to talk really in any circumstance. I think kids are generally pretty good at figuring out the best way for them to communicate, the most efficient way, the most effective way of communicating across environments. And what I usually tell parents is that communication is multimodal for everybody, especially in the time of Zoom. Sometimes we have a face-to-face conversation, sometimes a telephone call or an email. It really depends on the situation. And so certainly kids who are AAC users, they might have some situations when speech alone is getting the job done, and that's great. But there might be situations if there's a lot of background background noise, if they're in a group setting, if they're trying to communicate with unfamiliar partners where their speech alone is really not sufficient to get their point across. And it's really important in those situations that the child does have access to some type of AAC to prevent frustration and also to increase their functional communication. Because what we don't want is for them to shut down in a school setting because they know that other people just aren't understanding them.
Great, thank you. And so what should I be doing at home as a parent to help my child who has a motor speech disorder?
I think the best thing you can do is have really ongoing and open communication with your child's speech therapist. A good speech therapist will always give motivated parents specific activities and things to work on in the home environment. What you want to do is to see what the child's doing in speech therapy and then work on those same exact targets in the home environment. Doing this is going to increase generalization of skills. So what a child's learning in the clinic can then be applied and practiced in the home environment. And that's going to really depend on your child's individual treatment plan and what they're working on in therapy. So the number one recommendation I have is to make sure that you talk to your child's speech therapist and ask them what you should be doing in the home environment.
This next person talks about how their child lost speech at a point in their development, and they're asking about potentially trying an intensive short speech therapy program more than a long term. Is there any evidence about that?
I don't know that there's a lot of evidence for specific approaches for children who present with some type of regression, and the cause of the regression will probably play a large role on the child's ultimate prognosis. For instance, some children, if there's have had some type of neurological event, the acute onset of seizures is one thing that we sometimes see, where then a child's speech will be significantly impaired afterwards. I definitely think if you're seeing changes in your child's speech, the first thing you want to do is make sure that you do take them to a neurologist or a developmental pediatrician, someone who has a specific area of expertise in neurological conditions, to make sure that there's nothing significant going on that needs to be treated. Oftentimes, by treating the underlying problem, you might see an improvement of speech as well. In this particular situation, though, I'd say certainly speech therapy sounds warranted. I would maximize speech therapy until a point where you're seeing some progress with your child. So certainly, even if it's a new onset problem, I don't think there's a reason why you shouldn't still get your child into intensive speech therapy, the amount of which is probably going to depend on your child's individual progress.
And you mentioned that children, again, who are nonverbal or minimally verbal cannot be diagnosed with a motor speech disorder. Can you clarify exactly how much speech is necessary?
So what I tend to do in clinic is, if a child is not really using a lot of spontaneous speech, but they're still willing to attempt to produce words on repeat. So if I model something for the child and that they at least try to attempt to say what I'm saying, oftentimes I get a good enough idea of whether or not this could be a motor speech impairment. The kids who it's really challenging are the kids who are minimally verbal and really aren't willing to attempt to produce words on request, whether that's spontaneously, like labeling pictures, or even repeating what I say. So I would say at the bare minimum, it should be a child who has some spontaneous single words and also is willing to attempt to produce many other words when given a model first. Ideally, I feel the most comfortable making a diagnosis in children who will attempt phrase level speech, so word combinations.
And you mentioned a lot about structural problems that might cause some of these. Should I have my child see an ear, nose, and throat specialist?
So typically craniofacial differences or hearing issues aren't playing a role when it comes to motor speech impairment, but certainly those things could play a role in having poor speech intelligibility and some type of articulation disorder. So it's best practice anytime a child presents with a speech delay or some type of speech impairment that they should see an audiologist, simply to rule out hearing loss as one underlying cause for their language impairment. So that is always best practice. So I would recommend at least doing that to rule out hearing loss as a contributing factor to their speech impairment. Certainly if you suspect
suspect that they have some type of craniofacial difference, if you're suspicious of, possible cleft palate or, possible, issues with the dentition or resonance, then yes, then I think seeing an ENT to do a good evaluation might make sense. But certainly those things wouldn't be an underlying cause of apraxia or dysarthria, but they could cause poor speech.
Great. Thank you so much. And thank you for your time today. And thank you to everyone who joined the Q&A session. And we hope you learned some valuable information.